Okay, thank you. Welcome everyone to our Friday noon seminar. Today we have the pleasure of welcoming Arthur Lalonde. Arthur is a senior resident at the Harvard Medical Physics Residency Program and a postdoctoral research fellow at the Massachusetts General Hospital in Boston. He obtained his PhD in physics from UW in 2019. He had his thesis on investigating the use of multi-energy CT for Monte Carlo dose calculations in proton therapy, after which he joined the Harvard Medical Physics Residency Program in 2019, where he's been working on adaptive proton therapy. So today, Arthur will be talking to us about online adaptive proton therapy using CBCT data. So thank you so much, Arthur. Please take it away.
Thank you, Peter. Yeah, it's my pleasure to be here. Thanks for having me. So yeah, the residency program here is a three-year program. It's 1 year postdoc and followed by 2 years of clinical training. So the research I'm going to present here is basically what I've worked on during the first year of research as part of the residency. So my presentation, I'm just going to do a quick introduction of the subject, and then I'm going to focus more on two projects on which I've worked on during my postdoc here in the program. So as we know, radiation-induced side effects can be a big concern for patients receiving head and neck radiation therapy because they can have a significant impact on quality of life. And it has been shown that proton therapy can reduce the risk of almost all radiation-induced toxicities compared to photon radiation therapy. And a recent study by the Netherlands where they did some planned comparison between photons and protons as part of a triage for patients to see how many or which patient would qualify for proton therapy with well-established threshold in terms of NTCP reductions, concluded that about 35% of the patient eligible for planned comparison would qualify for proton therapy. That means having a clinically significant reduction in NTCP. And the symmetric benefits associated with proton therapy are due to the fact that protons stop in matter. So we can create those distributions that are more conformal with much reduced low dose path around the target, and hence reducing the dose to OIRs. However, those properties are kind of a double-edged sword because it also makes proton therapy much more sensitive towards any geometrical deviations from the nominal scenario. So that can be anatomic variations of the patient, but it can also be just set up variations from a fraction to another. And both are quite common amongst head and neck patients. And this effect is well illustrated in that figure here, where we have a planned comparison. On the planning CT, you really see how we can reduce the low dose with the proton therapy plan and have superior target coverage compared to the photon plan. But if we take that same patient, I think that verification CT is somewhere around week 5. The photon plan is basically the same, but in the proton plan, we have a loss of target coverage, some hotspots outside of the target. And this is just due to the sensitivity of proton therapy dose distributions to geometric changes of the problem. So if we would like to be able to maintain the benefits of proton therapy that we have in the planning CT and in a nominal scenario throughout a fractionated treatment, there are several options that can be investigated. And the first one I want to discuss is the idea of performing online adaptation of the treatment plan. So basically, we start with our planning CT. We create a treatment plan that meets the clinical goals for that planning CT. But then at each fraction, we update our representation of the patient anatomy, and we make quick changes to the plan to restore the initial quality at each fraction. So the first part of my talk is going to be about a fast scatter correction algorithm that we investigated for proton therapy dose calculation. So of course, if we want to be able to perform online adaptation, we need to have access to volumetric images of the patient in the treatment position. And nowadays, the most recent proton therapy centers are equipped with cone beam CT. It didn't used to be the case in the past, but it's more and more common. And here is an example of the most recently commissioned proton beam line at the Mass General Hospital. It's a system developed by Proton. So it's a half gantry. So because of that, we can't have the cone beam CT system on the gantry itself, but it's actually attached to the patient positioning system, the treatment couch. So we have our X-ray tube and flat panel that can rotate around the patient attached to the PPS. It's the system developed by Photon, which I think is the same on the imaging ring that Elekta sells as part of their brachytherapy solution. So cone beam CT provides this volumetric image of the patient. However, it is sensitive to scatter. So because the whole patient is irradiated in a single exposition or single acquisition, there are photons that are detected in pixels that are detector elements that where they shouldn't be detected. And this creates so-called scatter artifacts. And if we reconstruct the images without accounting for those, we get substantial artifacts that would make those calculations impossible, especially for proton therapy. So there's basically no way to obtain a reliable dose calculation on a uncorrected cone beam CT image if we don't account for scatter. So there are several ways of correcting for scatter artifacts. The first one is basically to physically limit the amount of scatter that is being generated or detected. So we'll call that scatter rejection. So we basically collimate the X-ray beam either at the source or the detector level. And the other approach where we don't need hardware is what we are going to call scatter subtraction. So we basically acquire a cone beam CT the same way as we would normally do, but then with some numerical methods, we're going to have a angle specific estimation of the scatter distribution. And then we can subtract that scatter distribution from what we measure to obtain a virtually scatter-free projection from which we can reconstruct a scatter-free image. And in terms of scatter subtraction, the most accurate method that is known to provide an accurate estimation of scatter is our Monte Carlo simulations. However, they are too computationally demanding for real-time usage. So if you want to perform online adaptive correction of the treatment plan, we cannot rely on Monte Carlo to correct our cone beam CT because it's just going to delay the whole process too much. But there has been recent work that have shown that scatter estimation could be substantially accelerated with deep convolutional network. So the objective of that study was to evaluate the performance of a deep CNN trained on Monte Carlo data in order to provide fast and accurate cone beam CT scatter correction in the context of head and neck adaptive proton therapy. So what we did is we modeled an Elekta XVI CBCT system in a GPU accelerated Monte Carlo code named MCGPU, where the X-ray tube spectrum was generated using the software SPECTRAL, which I think was developed at McGill. And we, using our Monte Carlo simulation, we generated raw CBCT projections and their associated scatter distribution for 48 head and neck patients that we split it in 29 for training, 9 for validation, and 10 for testing. So with that, we had just short of 14,000 projections available for testing and validation of the network, or pairs of projection and scatter distribution. And we trained a UNet built of 7 layers going from 16 to 1,024 feature channels that we trained to basically predict the scatter distribution given as input the raw projection only. So here are the results we obtained with our final architecture and optimal hyperparameters. So we can see, so in the first row here, we have the scatter-free cone beam CT image as constructed with using Monte Carlo calculated scatter distributions. We have on the second row, the uncorrected cone beam CT images, and on the third row, the images as corrected by our neural network. And these are just a subset of the 10 validation patients, so 6 of them. And we can see that when we show the difference between the images and the reference scatter-free image, we can see that with the neural network, we nicely reduce the scatter artifacts that we had in the uncorrected image. And also the interesting thing is the performance in terms of efficiency of the network. So the average computation time per projection was about 14 milliseconds. So if we have a whole volume of projections, about 30, if we have a 360 projection volume, we could correct the whole volume in less than 5 seconds. So just a bit more quantitatively, we looked at the error on the reconstructed Hansfield units. So mean error and mean absolute error were both reduced with the neural network compared to the uncorrected image. We had a mean error close to 0 with our network and mean absolute error of 13.4 compared to a mean error of 28.6 and mean absolute error of 69.6 using the uncorrected images. We looked into the impact of a few hyperparameters. One of them was the cost function that we used to train the network. So we looked at the mean square error and also the mean absolute percentage error. It turned out that the results were quite equivalent between the two cost functions. We ended up using the mean absolute percentage error because it was slightly more performant, but the impact was deemed minimal in terms of accuracy or HU accuracy. We also tried to train the network to predict different quantities. So the first one is what I just described. So going from the raw uncorrected projection and trying to learn the what we call normalized scatter distribution. So basically the 2D scatter distribution divided by the open field intensity. And we also try to bypass this scatter subtraction method. So going directly from the raw projection to a scatter-free projection. And here we saw there were differences depending what we were training the network to learn. And the best results were obtained by trying to learn the scatter distributions and not the scatter-free projection directly. One important aspect that we also investigated was the impact of the accuracy of the CBCT system modeling. Everything I've presented so far is based on Monte Carlo simulations, but of course, what we want to make sure is that we're able to correct actual physically measured cone beam CT projections. So we looked into the sensitivity of our model to discrepancies between the Monte Carlo model and what we used in the model, the system with which we use it in the clinic. So to do that, we added a 2 millimeter aluminum filtration to the spectrum for between the training and testing. And basically we compared the results with and without the added filtration. And here we're comparing the distribution of errors for the uncorrected cone beam CT, the one where the spectrum is the same for training and testing. And here we added a 2 millimeter aluminum filtration. So basically we see some effect. The accuracy is not exactly the same. We have some artifacts around the bony anatomy, but in general, we still have a substantial improvement compared to the uncorrected image, and general overall good distribution of error, nicely centered around 0. So far we looked into accuracy in terms of image quality and image and HU accuracy. Of course, what we're interested into for that project was the impact on dose calculation accuracy. So we created the IMPT plans for our 10 test patients in RayStation, and we optimized treatment plans on the scatter-free cone beam CT images, and then we recalculated those plans on the uncorrected CBCT images and those corrected by our neural network, and performed gamma analysis between the reference dose distributions and those calculated on the different CBCT data sets. And we had an average 2% 2 millimeter passing rate of near 99% with the cone beam CT images corrected with our neural network, compared to below 70% with the uncorrected images. Similarly, we looked into the impact of the spectral accuracy in terms of dose distribution, and it's basically just mirroring what we had in terms of image quality. So the passing rate is slightly reduced when there's adult filtration between testing and training and testing of the network, but we still have a very satisfying result and a significant improvement compared to the uncorrected images. So now let's talk about actual experimental images. So everything I've shown so far was in the Monte Carlo bubble, let's say. So we took our Monte Carlo trained network and we applied it to experimentally measured images. So to do that, we used head phantom and anthropomorphic head phantom, and we used the CT as a reference in terms of scatter-free image. So we wanted to mimic the CT. The reason is we thought the CT was a better surrogate of what we want to achieve in terms of dose calculation for our patients, since the original plan is optimized on the CT. And also we didn't want to propagate errors that could be in our Monte Carlo model. So we thought the CT was a good and reliable ground truth. And we also get rid of any potential registration accuracy or deformation between CT and cone beam CT by using a phantom and not patient data. So we can see that with the neural network, we have a good, we were able to basically remove that cupping artifact that we have on the uncorrected image. Of course, the accuracy is not as good as when we stay within our Monte Carlo environment, but we are still able to correct for most of the scatter artifacts. And we can see that most of the errors are actually around the bones, and we hypothesized that this was due to volume averaging, because we didn't have the same resolution in our cone beam and in our CT. Now, in terms of dosimetric accuracy, so we simulated a single PA proton beam on the head phantom and did the same exercise as I showed previously. And in terms of proton range accuracy, we obtained about a millimetric agreement between the scatter corrected cone beam CT and the planning CT, and we were off by a few centimeters in the uncorrected cone beam CT. Now, the final step was to evaluate this method using patient data. And so for the reasons I've discussed a bit before, we didn't use the planning CT for the patient data because we judged that any setup reproducibility or anatomic changes between the planning CT and the cone beam would make the CT a not perfect representation of our target or what we're trying to reproduce. So instead of using the planning CT, we used a empirical method that was shown to be satisfying for proton therapy dose calculation. It's just a bit slow for online adaptation. So it's an empirical approach that uses the CT as prior, but only for the scatter estimation. So we're basically starting from the planning CT and we subtract the differences in the projection domain between our planning CT and the cone beam and the uncorrected cone beam CT, and we perform some smoothing to obtain an estimation of the scatter distribution to reconstruct a scatter-free image. So that's kind of an empirical approach that was validated for proton therapy, and we used it as a reference for our patient data sets. So we had 3 patients for the test group for whom we had cone beam CT images taken on one of our electel linacs. So here are the results we obtained. So in general, we had good agreement between the neural network prediction and the reference method that I call CBCT prior. The gamma passing rate were not as good as for when we were staying in the Monte Carlo environment. So we had, when using the 2% 2 millimeter passing rate, we were just below 80%. The 2% 2 millimeter criteria, we were just below 80% in terms of passing rate. But when we used a bit more permissive at 3% 3 millimeter, the passing rate was raised to close to 99%. And the reason for that is we believe, even though we consider that as a reference, it's not a perfect scatter-free image. There are some underlying uncertainties in that for that approach as well. So we believe that the reality is probably somewhere in between what the neural network and the the prior approach are suggesting. But the fact that we get good agreement with this clinically approved this reference approach and our neural network, we had good agreement for the 3% 3 millimeter criteria, where it was quite a good result for us. So the conclusion of this work was that our network was able to provide Monte Carlo equivalent scatter correction, or at least clinically acceptable scatter correction, in just a few seconds. When looking into different cost functions, we observed that the optimal HU accuracy was achieved when we used the mean absolute percentage error cost function trying to predict the scatter distribution, rather than trying to bypass the scatter subtraction step and trying to learn directly the scatter free projections. We've shown that the model was robust, again, moderate spectral discrepancies between training and and testing of the network. And basically, we've achieved accurate proton range prediction and IMPT dose calculation on the scatter corrected cone beam CT images. So we concluded that this method would be suitable for head and neck adaptive proton therapy. And for more details, I encourage you to look into a PMB paper that we published about this work. So this brings me to the second part of the talk, where I wanted to look into more clinical application of this scatter correction tool that we are clinical simulation or evaluation of the clinical potential benefits of this approach. So the second part of the talk is about investigating or quantifying the impact of online adaptive IMPT for the treatment of head and neck cancers. So going back a little bit, so we have this issue of proton therapy being very sensitive to any geometrical changes, which can be both anatomical changes, weight loss, tumor shrinkage, or setup reproducibility challenges. And one solution, or at least the one, sorry about that, the one we want to look into is, or the one we looked into was performing online adaptation of the treatment plan. Of course, there are other solutions, and the other one, and which is already being implemented in the clinic, is to increase the robustness of the treatment plan upfront with robust optimization. So create a treatment plan that, for a realistic range of setup errors and anatomical changes, will still fulfill the clinical goals. So the general idea of robust optimization is to get our planning CT and a set of anticipated realistic clinical variations. So this can be setup errors or changes in the anatomy of the patient, and create a single plan that will fulfill the clinical goals for all cases simultaneously. So the objective of this work was to assess the feasibility of online adaptive proton therapy for the treatment of head and neck cancers, and to compare it to robust optimization, considering realistic setup variations and anatomical changes. So we took a cohort of 10 head and neck squamous cell carcinoma for whom we had daily cone beam CT. We had between 31 and 35 CBCT per patient, with a median of 33 cone beam CT. And on the planning CT, there were 2 target volumes delineated by a radiation oncologist, a high-risk CTV, for which we prescribed 70 gray, and a low-risk one where 57 gray was prescribed. And we had a set of OARs, including parotid glands, constrictor muscles, larynx, for which we applied the Quantec dose constraints. And then for each patient, we created 3 plans. So the first one was created using what we call classical robust optimization, or CRO, where we optimized the plan to the CTV volumes considering a 3 millimeter isotropic setup uncertainty. So we basically have our planning CT and then isotropic shifts of the patient in all 6 directions for a total of 7 scenarios. Then the second robust optimization approach that for which we created a plan for each patient is the so-called anatomical robust optimization, or ARO, where in addition to the setup uncertainty, we added the 2 first fraction cone beam CT in order to introduce some variability in the patient positioning. Now, this was done because we didn't have access. So this approach is also known as multi-CT robust optimization. And the idea would be that prior to treatment, you get more than one planning CT for the patient. So the idea is not to wait until the first fractions to perform that approach, but because we didn't have multiple CT of the patients before treatment, we used the 2 first fraction CTs as a surrogate of multi-CT robust optimization. And then finally, we optimized a third plan where we optimized considering only the planning CT without any form of robustness, but that we adapted online at each fraction. For all plans, we used a simultaneous integrated boost technique. So both CTVs were treated simultaneously, and the initial plans were created using multi-criteria optimization. So in order to perform the daily adaptation, we used a in-house developed workflow where the first step is to start from the raw cone beam CT of the patient and perform fast scatter correction with the deep CNN that I just presented. So there we get a scatter corrected cone beam CT. Then we take the planning CT and we perform deformable image registration between our planning CT and the scatter corrected cone beam CT. And we use the deformation vector field from the planning CT to the scatter corrected cone beam CT to propagate the contours to the daily anatomy. From there, we used a in-house developed GPU accelerated Monte Carlo dose calculation called MOCI, with which we get a daily dose distribution. Then we assess this dose distribution, and we reoptimize. If the clinical goals are not met, we're gonna reoptimize the plan using a so-called constrained spot intensity reoptimization to create a adapted plan that we're going to use for those calculations. So I'm just going to want to give a bit more details about the way we reoptimize the plan. So like I said, we call it a constrained spot intensity reoptimization. The idea is that we only reoptimize a subset of the more heavily weighted proton beamlets in the plan. So an IMPT treatment plan is basically defined by pencil proton beams, which all have weight, XY position, and an energy. And we kept the energy and position fixed for all beamlets, and we only reoptimize the weight for just a subset of weights. So basically that summarized the workflow. We start from our initial treatment plan. We select the subset of the more heavily weighted beamlets. We keep their energy and position. There's a subset that we don't even change the weights. We reoptimize their weights to fulfill the clinical goals given the daily anatomy, and then we obtain an adapted plan that we're going to use for that treatment. So overall, the treatment time for adaptation using our online adaptation workflow was ranging from 8 to 22 minutes total. The median time was 12 minutes. And most of the time was spent on the GPU dose, the GPU accelerated Monte Carlo dose calculation, and the reoptimization of the plan. The image processing was actually just about 2 minutes of that workflow. And we're expecting that with improvement in the way things are done, so there are things that are done sequentially that could actually be done simultaneously. Also, we're not using the most efficient hardware and codes at the moment. It's still something we're developing. So our objective would be to have this, since everything in there is automated, we're expecting to be able to bring that total time around 2 minutes. So going back to our patient cohort, so what we did is we've tracked the dose for each fraction for each patient using the daily cone beam CT, and we deformed the dose back to the planning CT to perform dose accumulation. We looked into the coverage of both CTVs, the dose to some OERs, as well as the integral dose to healthy tissues. And we looked into, or we established significance of the differences between the different approaches using a Wilcoxon sign rank test, using stating that a p-value lower than 0.05 would be considered statistically significant. So here are the results in terms of target coverage for the low-risk CTV on the left and the high-risk CTV on the right. What we're showing here is the difference between D98% and 95% of the prescription dose. So basically, which was our clinical objective when we optimized the plans. So a negative value means that the clinical goal was not fulfilled for that target and that patient. So first thing we can see here is that only the online adaptation in blue was able to fulfill the clinical goals in the cumulative dose distributions for all patients and both CTVs simultaneously. Using anatomical robust optimization, actually 9 patients out of 10 for the goal is fulfilled in terms of coverage for each CTV. And then for classical robust optimization, there are actually 5 patients where the clinical goal was not met in the low risk CTV, and 2 patients where it wasn't met in the high risk CTV. In terms of those 2 OARs, so here we are plotting the mean dose to constrictor muscle, the integral dose, mean dose to both parotid gland and the larynx, as well as the dose to 1 cc in the spinal cord. And same color scheme as in the previous slide. So we have online adaptation blue, anatomical robust optimization in red, and classical robust optimization in yellow. First, by comparing the 2 robust optimization approaches together, we can see that so we had improved target coverage using anatomical robust optimization. And interestingly, what we see is that this superior target coverage compared to classical robust optimization is not obtained at the cost of a higher dose to most OAR. So actually, there was no statistically significant differences between the dose to most OARs using either anatomical robust optimization or classical robust optimization. However, the integral dose to healthy tissues was increased using anatomical robust optimization, which was something we were kind of expecting. The more robust the plan, the bigger the integral dose usually is. Now, in terms of comparing online adaptation with the robust optimization approaches, the dose to OARs was reduced to almost all OARs using online adaptation. The only non-statistically significant differences were for the ipsilateral parotid gland. So online adaptation did not improve the mean dose to the ipsilateral parotid gland compared to both robust optimization method, and in the contralateral parotid gland, the improvement was not significant compared to anatomical robust optimization only. In this slide, we present the evolution of the target coverage as the fractions were delivered for 5 of our 10 patients. And one thing that we can see is that the evolution is actually quite different from one patient to another. We have a case here in patient 3 where the patient lost weight progressively during treatment, and we can really see how that affected the coverage for both robust optimization method. Basically more for classical robust optimization than for anatomical robust optimization, but really only the online adaptation approach was able to maintain the target coverage satisfying during the whole treatment. But we also have patients like patient 5 where we have more of a random or not a systematic trend, but more fluctuations of the target coverage. And again, target coverage is good with online adaptation independently of the type of changes and variations in the patient anatomy and setup. So this gives a little bit more concrete example of the impact of online adaptation in terms of dose distribution. So we have the cumulative dose distribution for online adaptation for 3 patients on the left. In the center, we have the cumulative dose distributions using anatomical robust optimization, and on the right with the classical robust optimization. So in patient 2, we can see that anatomical changes and setup variations during treatment induce some cold spots in the classic robust optimization approach, although we didn't have that in both online adaptation and anatomical robust optimization. However, if we look at the blue isodose, which is the 35 gray isodose, we have a much more conformal result with the online adaptation. That is because we don't have to add dose outside of the target volume to increase robustness of the treatment plan. Patient 3 here is the case where we had weight loss, progressive weight loss during treatment, and you can see that neither classical robust optimization and anatomical robust optimization were able to account for those changes because they were not included basically in the set of anticipated variations where we created the initial treatment plan. But by adjusting the plan daily, we were able to account for those changes. And then patient 5 is a case where we had more of a inconsistent repositioning of the patient. So it's a treatment of the base of tongue and positioning was actually challenging from one fraction to another. And we have a cold spot in the high-risk CTV coverage in using classical robust optimization. But here it's a good example of how by adding a few examples, a few representation of the patient anatomy using multiple CTs to optimize the plan. In the case of anatomical robust optimization, we're kind of able to anticipate a bit more variations in the setup of the patient. And in that case, we didn't get that cold spot in the anatomical robust optimization method. But again, online adaptation was basically performing well independently of the type of changes that affected the treatment plan. So the conclusions of that work were that online adaptation met the clinical goals for both CTVs simultaneously in all patients, compared in 8 out of 10 for anatomical robust optimization and only 4 out of 10 using classical robust optimization, which is kind of considered the gold standard as of now. The increased robustness that was associated with anatomical robust optimization over classical robust optimization was not associated with a significantly higher dose to most OARs, but it did increase the integral dose to healthy tissues. Using online adaptation, however, we were able to significantly reduce the dose to most OARs, as well as the integral dose compared to both robust optimization methods. And overall, our study suggested that the superiority of online adaptation over state-of-the-art robust optimization approaches to maintain the benefits of IMPT for treatment of head and neck cancers when we consider both setup variations and anatomical changes. So those results were published in the Green Journal last year if you want to get a bit more details. And just before wrapping up, I want to quickly discuss 2 other studies that were performed in the group on adaptive head and neck proton therapy. So we did a study where we compared we investigated the impact of the frequency of adaptation. So we compared daily and weekly adaptation. And generally the conclusions of that work was that for most patients and in terms of OAR sparing, the results were very similar between weekly and daily adaptation. The reason being that we're basically looking at mean dose, which doesn't really change that much on a day-to-day basis. However, we demonstrated that in terms of coverage, there are some patients where we had benefits using daily adaptation rather than only performing weekly adaptations. And those were patients where we had more of a random change rather than a slow progressing change in anatomy, which kind of makes sense. And the other study I just want to quickly mention is so everything I've presented so far was CBCT based online adaptation because that's the technology we have at MGH, but other centers are also considering using CT on rails rather than cone beam CT. And so we compared what would be the impact of using one versus the other, assuming equivalent image quality, which is maybe kind of a bold assumption, but we mostly looked into the impact of the added uncertainty in terms of positioning going from the CT on rail to the radiation isocenter. And basically our conclusion was that if the added uncertainty and positioning was not exceeding 2 millimeters, which is pretty large, the CT on rail would be equivalent to cone beam CT in terms of target coverage and performance of the overall adaptive workflow. And just before wrapping up, I just want to discuss the next few steps of this whole project. So everything I've presented so far was based on photon patients, because when that project started, the beamline, the proton beamline with cone beam CT was not commissioned, or the commissioning was not finished yet. So we didn't have CBCT data for proton patients. So what is currently going on is really translating everything we've built so far and developed using a photon-based CBCT model and photon-based patient to translate that to our proton room with cone beam CT system. And hopefully you would like to validate the whole workflow with phantom measurements. And the other step that is going to be very interesting is to integrate in the whole adaptation workflow another project that has been going on for quite some time at the MGH, which is prompt gamma range verification. So it's using the gamma rays being emitted at the end of range by proton beams following nuclear interactions in the patient. And with that, we can perform in vivo range verification, basically. And the idea would be to integrate that and significantly reduce range uncertainty margins, and that could enable near marginless intensity modulated proton therapy. So that's a very, very interesting challenge, and would have a great impact on the whole adaptive process. And finally, everything I've shown so far is for head and neck, which kind of made sense in the sense that we have a lot of anatomical changes and setup variations from fraction to fraction, but we don't have a lot of intrafractional motion. So everything I've shown so far is to deal with interfractional changes, but there are other anatomical sites which where we see potential benefit of performing online adaptive proton therapy. So with that, I would like to thank you for your attention and of course, the support of my colleagues.